Hello, class. My name is Yves-Amougou. I'm a psychiatric nurse practitioner, and this is a presentation of my DNP project on the utilization of cognitive behavioral therapy to improve the chronic use of benzodiazepines. Here are my committee members, and I would like to thank each one of them, including Dr. Lisa Stirrer, my chairperson, the second reader, Dr. Jennifer Hopner, my community support, Dr. Mary Morenja, and Dr. Diaby Nasaratu. Thank you for your feedback as I was going through this inquiry. Special thanks to Dr. Mark Pauls, Maryville University statistician who did the data analysis. And last but not least, Miss Christy Matej, who was very instrumental during the process of enrollment and during the various deadlines that need to be met over the last 2 years so that this DNP program can be completed. Thank you all. Background and signification. Benzodiazepine are among the most commonly and widely class of medication prescribed in the United States and globally. They have been approved for short-term use of multiple conditions, including uh, seizure disorder, anxiety, insomnia, among many. This list is not exhaustive. And uh, the guideline recommend the benzodiazepine use for no longer than 4 weeks. Prescription patterns show that many patients have been receiving benzodiazepine for years and even decades with multiple side effects, including agitation, birth defect, addiction potential, and even death. Unfortunately, when prescribers are seeing patients in clinical setting, uh, physician, nurse practitioner, and physician assistant are under the pressure to alleviate the symptom that led to a patient seeking help at those clinics. And many times, doctor, nurse practitioner are just pressed to prescribe medication with addiction potential, such as benzodiazepines. Study by Lewin and al. Has shown that there has been a marked increase of benzodiazepine-related emergency room visit with benzodiazepines death. Overall, benzodiazepine, whether it was benzodiazepine obtained with prescription or benzodiazepine obtained in the street or illegally, have shown that there has been a marked increase in patient death. About 1% have obtained the benzodiazepine through their regular physician, and about the benzodiazepine death has increased by 21% about among the patients who have obtained benzodiazepine illegally, and 42% among the patients who have obtain it through their physician. And with those staggering numbers, a lot of healthcare leaders are now thinking about ways to change that trend, and which lead to the pick-up question. In adults with chronic benzodiazepine use history who have agreed to medication they're prescribing under the supervision of a physician, what is the effect of cognitive behavioral therapy in comparison of no intervention on patient benzodiazepine use reduction? The review of literature was done by using Maryville University, and the first uh, uh, query yield about 40,000 results. After multiple use of filters, we were able to reduce the number of article to about 16 articles. All articles have the strength, and the main strength of evidence from the review of literature show that many of the selected articles show that cognitive behavior therapy affect benzodiazepine use reduction over time, which was the primary goal of the PICO question of the investigation. And I've listed the article by Chapoutot and al. article by Mark and al., and the article by Otto and al., who were demonstrating those facts. And all selected article, all 16 show that the study have followed ethics and ethics rule on a human subject. Weakness of evidence show that none of our article use testing such as serology testing to gauge whether the patient had benzodiazepine on board, because some patient may have either use benzodiazepine but report that the benzodiazepine use have reduced. So we depended a lot on a patient report during that inquiry and on those review of literature. The gap in literature review show that many studies were conducted in various parts of the world with various demographic, which make those different studies difficult to replicate in America or in any other part of the world. And this was the case of the study by Fernandez and al., the study by Tenenbaum and al. As well. Finally, none of the articles show any guideline to use for benzodiazepine use reduction. And for the theoretical framework for this inquiry, we use the three-step theory of change by Kurt Lewin for the change. And the three-step change theory entails the step number one, unfreeze, step number two, changing, and step number three, rephrasing. And the three-step theory of Lewin is based on the fact that all human activity are marked by the fact that they are opposing forces. And when the opposing forces are going, some forces are driving force and the other force are opposing force or restraining force. And an equilibrium or status quo is reached when the two opposing forces are equal. And change occur when one of the forces is greater than the other one and affect the change one way or the other. In the case of this inquiry, the unfreezing step occurred at the time that patient expressed their desire to prescribe or to reduce the use of benzodiazepine, either under the physician's supervision alone or supervision of physician along with cognitive behavioral therapy. And then the changing is whatever occurred during the actual work of benzodiazepine use reduction or benzodiazepine prescribing. Once we reach the target goal, which is reduction of the benzodiazepine or complete benzodiazepine prescribing, then we have to refreeze where we are so that we create a new normal, a new statu quo where the patient cannot function either with less benzodiazepine or with no benzodiazepine at all. And and so that's the three steps of the Lewin theory that was used for this inquiry. The study design was descriptive study. That was a 6-month chart review, retrospective chart review on patients seen at a local psychiatric clinic in the southeast of United States. And during that chart review, patients were selected based on inclusion and exclusion criteria, and from patients who have met those inclusion and exclusion criteria, the investigators selected 15 patients who have agreed to benzodiazepine prescribing alone under the supervision of a physician, and 15 patients who have agreed to benzodiazepine along with cognitive behavioral therapy led by a trained therapist. And the focus of the inquiry was to gauge the benzodiazepine use reduction over a 6 month period. Uh, the scholar hope that benzodiazepine use reduction will be superior for patients who have opted to have cognitive behavioral therapy as an adjunct to benzodiazepine taper under the supervision of a physician. More on the methods and designs is about cognitive behavioral therapy. Cognitive behavioral therapy is an evidence-based psychotherapy that has proven to be effective intervention to manage a patient with various conditions, including depression, anxiety, and many other psychiatric disorders. Cognitive behavioral therapy involve effort to change a patient distorted thinking pattern with treating them with problem solving skill in order to cope with difficult or anxiety producing conditions. Cognitive behavior therapy has many variants, including uh, cognitive behavior therapy I for patients with insomnia and other interventions such as mindfulness-based cognitive behavioral therapy. The sample were selected based on patients who have met predetermined inclusion and exclusion criteria, and originally the clinic manager select randomly 100 patients who have met uh, uh, those inclusion and exclusion criteria, and the list of 100 patients was given to the investigator. The investigator carefully selected among that group 15 patients who agreed to slow medication taper alone, and a second group of 15 patients who agreed to therapist-led cognitive behavioral therapy along with slow benzodiazepine taper. Only the identified data were collected uh, in in a data collection sheet, and once the investigator was able to have 30 patient total as described previously, then the investigator sent all the data to Dr. Paul for data analysis, and all the data collection sheet and any other tool used for this inquiry was returned to the clinic manager for final disposition. For the data analysis for this inquiry, the z-test for the difference of proportion was used. The z-test of difference of proportion is a chi-square test. The test was used to compare the proportion of two independent samples with a null hypothesis, meaning that the two groups in benzodiazepine use reduction were not significant. That test is used to analyze whether two groups are significantly different in benzodiazepine use reduction. And the raw data show that 6 out of 15 patients were able to reduce the benzodiazepine use with a combination of CBT with benzodiazepine taper, where where 4 out of 15 patients were able to reduce the benzodiazepine with slow medication taper alone. And the data analysis was now to uh, to decide whether cognitive behavior therapy was significant in benzodiazepine use reduction. From this raw data, it appeared that the combination between cognitive behavior therapy along with slow medication taper was superior of slow medication taper alone. And after that analysis completed by Dr. Pauls, it appears that the p-value of the data analysis was 0.2 0.195. This p-value is above 0.05. Therefore, we cannot we don't have enough data to state that cognitive behavior therapy is the reason why there's a significant difference between the benzodiazepine use reduction between the two samples. In addition, this study has a power of 0.1 0.18, and this power and is so low that it also show that we cannot say with certainty that CBT was able to shift the uh, the the study one way, meaning that cognitive behavior therapy along with CBT versus the other sample of patients who have only used medication taper are not significantly different statistically. There are many limitations from the study. The first limitation is the fact that the sample was relatively small. Only 15 patients who have agreed to medication taper alone and 15 patients who have agreed to medication taper along with cognitive behavior were selected. And in addition, the power analysis was 0.18975. This is a low power analysis. And in order for us to overcome those limitations, we may need to have the similar study with larger sample. In addition, cognitive behavior therapy is inherently associated with some skills that the clinician has, the one who lead the therapy, and how that clinician interact with the participant. And because of those uh, specific between the group leader and the different group member, so one may say that it's difficult to generalize the results. Another limitation for the study is that the study did not address the alternate psychotropic to address the anxiety, which was the primary reason of patient using benzodiazepine. And the last is that the study did not address the sustainability of benzodiazepine use reduction over time. All of these limitations may be seen as a reason maybe for further study so that we may continue to take care of patients who have been using benzodiazepine for a long time. The discussion, and for the discussion, is that the goal of this inquiry was to gauge the impact of cognitive behavioral therapy on benzodiazepine use reduction among patients who have been receiving benzodiazepine for a long time. The raw data showed that there was a superior result among the patients who have used the combination of benzodiazepine helper with cognitive behavior therapy in benzodiazepine use reduction. However, as stated in the previous slide, the data analysis didn't show that benzodiazepine significantly reduced benzodiazepine among the sample. So therefore, there is a need for further study with a sample that is more characteristic of the general population so that the study can be now generalized. Finally, benzodiazepine, the prescribing should not be a panacea. We shouldn't have a knee-jerk reaction where all patients who have been receiving benzodiazepine for a long time have to be prescribed of medication. Benzodiazepine have been and continue to be used in clinical setting because they are good medication and they are good medication that has addressed some need, some valid need of a patient. Therefore, we have to be very careful to not just prescribe benzodiazepine when we see a patient who has been receiving medication for a long time. If not, patient need will not be met, and I don't think that that's the reason why we do what we do as healthcare provider. Implication for clinical practice. At the local practice, this inquiry have served a reminder among all medication provider to prescribe medication, not just benzodiazepine, but benzodiazepine according to guideline. And also at the local level, there has been a greater interdisciplinary collaboration among clinicians at the clinic for optimal patient outcome. For APRN in general, these studies have reinforced the role of DNP preparedness role as catalyst of quality improvement for positive change in patient care. At a community level, these inquiries have shown that there is a need for more research funding, so that we can continue to reduce safely benzodiazepine use, especially the inappropriate benzodiazepine use among people who have been receiving it at the for a long time. And also at a community level, uh, there can be policy change in, for example, reimbursement, so that a study that was done in Spain have shown that when there's a policy change on how benzodiazepine are reimbursed, there's a tendency of reduction of those medication if the patient has to pay a little more. Um, and there's not one size fit all. You have to just be creative in how you change policy at the global scale. In conclusion, benzodiazepine remain an important medication option in clinical practice, and that's why that medication has been used for so long. So long-term use of benzodiazepine is not necessarily inappropriate use of benzodiazepine. This quality improvement has highlighted the need for frequent reassessment of patient need for benzodiazepine, just like for any other psychotropic medication. The other element that this quality improvement have highlighted is that benzodiazepine the prescribing should be coupled with alternate intervention, including benzodiazepine, uh, other medication alternate to benzodiazepine, such as SSRI, SNRI, to target anxiety. Anti-anxiety medication such as Panolol, beta blockers, or uh, other medication like Vistaril can be alternate to benzodiazepine, and they should be put on the equation. Uh, Finally, uh, a study have shown that over time, patients may lose the benefit of cognitive behavior therapy. Therefore, patient may need cognitive behavior therapy refresher, so that they may revisit their cognitive distortion and how it affects their reliance on benzodiazepine. And these are the main conclusion for this inquiry. And panel, our and community, I would like to thank you for your attention to this presentation, and I will be glad to answer to any question that you may have. These are few references that I've used for this presentation, and these are the last page for the reference. Thank you very much for your time, and I'm looking forward to your question. Thank you.